So what is clinical product? Design, the implementation, the safety, and the advocacy of safe and robust, clinically focused products. But it's about bundling that together and making sure that the right structures are in place around those, so that when they are deployed, they make sense, they work for everyone, not just someone sitting in procurement, but actually the frontline user, and it's tying all that together. Is it product management with a clinical lean? It probably is. It's making sure that none of those voices in the room get ignored. If you get it right and you build the right stuff, then it's not only implementable, but it can be scalable, and that has huge ramifications in terms of impact and doing good.
Lawrie, welcome to Healthtech podcast, mate. How you doing?
Yeah, good. I'm excited to be here. It's an honour.
Yeah, it should be fun. Should be fun. I'm also a little bit I was going to say in awe, but I don't know what the right term is. Like, Daffyd from Concentric came on this podcast and he said an amazing phrase to me, which is that when you leave medicine, you freeze your seniority at the point at which you have left. And so now where I find myself is on a podcast with a consultant anaesthetist. And now I feel like you're my boss and I feel a little bit scared of you. So imagine me I'm going to be a little bit subservient, I think, in this podcast and ask you like, is it okay if I ask this? So,
you're the first person who I interact with in any other environment who's subservient to me. So that's great.
Well, get ready for it, because as I say, my seniority definitely froze when I left medicine as SHO / a week as a registrar or whatever I did. But never did the exams. So never did part 2 of the exams. So I've always got that hanging over me that the consultants when I left were like,
it's always there. It's always there for you. You can always do that. I wouldn't recommend it, but
I spectacularly failed in fact, no, I didn't spectacularly fail it. I just about failed the OSCE, but I did spectacularly fail the Viva first time round, because I passed the MCQs first time and thought, this is fine. This will be absolutely a walk in the park. Obviously, it was not. The anaesthetic exams, famously, are they the most difficult, do you think? Exams
if you ask an anaesthetist, they're always going to say yes, aren't they?
They are.
But yeah,
of course they are. Thank you. That was, I only asked you to validate it for me.
No, it's it's dangerously a monathon, but like, the exams are grim, and you're like, I've got so much sympathy for residents out there who are juggling really brutal on-call rotas, rotating hospitals, often have got young families, have got, serious clinical commitments, and on the side, their hobbies include revising for exams, which take about 4 hours of revision a night. Like, is absolutely grueling.
Especially when you're learning the pressure that gas is stored outside the hospital and how it's piped in. There's those moments where you're like, hold on a minute, is my time better spent doing something different? Probably, but do I want to pass this exam? Absolutely. And it feels like the ticket to freedom, doesn't it? Like, once you have passed that, I imagine, I wouldn't know the feeling, but if you have passed the FRCA, I imagine that must feel like, now I just have to do my day job. Surely that's fine.
Yeah, I mean, funnily enough, that my experience of going through training was like, I don't know, it felt quite hard work. It was quite a grueling process, and you have these hurdles, and you can only see the next one you've got in front of you. And so, it might be an exam, or it might be a project, or it might be a job interview, or whatever it was, and then you there's this nice little lull afterwards, and then the next thing kind of rears up on the horizon, and that's I guess that's kind of the nature of life. But my kind of like slightly alternative portfolio career only got established once I'd got over what felt like the final hurdle, which is when I got a consultant job, and that until then it was absolutely relentless, just going from one project to another to doing some research, doing a big QI project, constantly being involved in stuff, whether it was exams or whether it was stuff, or just sometimes just kind of trying to keep the wheels attached to my life, with a wife who was also juggling similar commitments and stuff like that. So I've got a huge amount of sympathy for trainees coming through the system, because it is hard. It is really hard.
Well, I'm looking forward to getting into this with you, because you have put a portfolio career together, working at DrDoctor, as well as doing lots of other things with conferences and a bit of entrepreneurship yourself, it sounds like. And yeah, there's a lot for us to get into. And I guess that would be my first question as to the pressure that clinicians face at the moment seems enormous. Clinically, there are strikes going on. Practically, there are health tech things happening, AI scribes that might take some of that admin pressure away. But I'm really interested because we don't have many, full, practicing clinicians on here, frankly. And you see health tech from two different sides. You see it from the side of working in it, and you see it from the side of having it done to you, I imagine, as a clinician. And so just to orientate us a bit, like where are you in life and all those different things? Give us the rundown of who are you and what are you up to? And yeah, just let us know what the practical reality is on the ground floor. I think that's a nice place for us to start.
Yeah, so I kind of always introduce myself as a consultant anaesthetist first. So 2 and a bit days a week, I work at Gloucestershire hospitals. So it's a split site trust. It's massive. It's really busy. It's a very exciting and interesting place to work. And it's if anyone's looking for a job, it's a brilliant place in terms of loads of interesting stuff going on. And lovely. It's and fundamentally like a really, really nice bunch of colleagues, which is the best thing.
Nice.
And I always, if your list finishes early and you sit in the coffee room and suddenly you look at your watch and you see it's like 6:15 because you've just been having a good chat with your mates, that's golden.
That's lovely.
So I'm incredibly lucky to do that. And that's kind of front and foremost of kind of what I identify with, really, is that clinical role. What that actually involves is probably kind of 70-ish% of my time is giving anaesthetics. And then the rest of my time I'm in pre-assessment clinic. So I do a little bit of outpatients, but predominantly putting people to sleep for operations, which is, this. It's an amazing job. It's a huge privilege. And one of the things I absolutely love about it is you are interacting with people at a stage where pretty much everyone's terrified. So no one really wants to be there. I think the only people who are excited to have an operation are people having boob jobs and people having a kidney transplant. Like genuinely, like pretty much everyone else is like there for some kind of misfortune. Yeah. And what you can be is you kind of, the whole point of a CCT in anesthetics is that you can come out being able to do the technical skills, but what you can do. And I remember like so clearly as a junior trainee working in Exeter, there was a consultant who just held the patient's hand just as they were going off to sleep and was just super kind, just super empathetic towards them. And that's always kind of stayed with me in terms of the fact that you can do so much technically, but actually what patients remember is whether or not you are kind and compassionate towards them. So that's kind of front and foremost of what I try and do. I try and deliver kind of good clinical care. Then when I'm not doing that, I've got a couple of other roles. The biggest one is with DrDoctor. So I've been there for a few years now. I was on the kind of clinical transformation side of stuff. And now I've moved into the product side. I'm clinical product lead. And that's brilliant. I can talk about that all day. But it's a really, really interesting.
And we shall.
Hopefully not all day. But yeah, it's a really, really interesting and kind of sometimes challenging, but really eye-opening space to be in. Then the kind of other kind of form roles I've got a couple of non-executive director roles, which are really insightful, really eye-opening. One's for a big research foundation, and one's for a kind of community diagnostics provider in the Southwest. That gives me a totally different perspective. And then when I'm not doing those things, I'm dad to 2 little girls and husband, and juggling other stuff, and lots of other things going on.
That's amazing, man. I think for lots of people that if you'd have said that to me when I was an F1, F2, I would say this guy's living the dream. This guy is absolutely done. Like, I would have probably thought there's actually a role model, and I did struggle for that quite a lot in my clinical training of who's got the career balance, the life balance, etc., that that I would want. And so congratulations to you for getting all that together. Like I imagine what most people come on here and say is that, oh, it can always look like well thought out and all these things, but it's, you know, you're just rolling from one thing to the next and bumbling this career together. But how has it felt for you putting that together? Because have there been like clear paths to that? Did you have anyone to look up to?
So the last question is easiest no. And I've kind of looked for role models. And when I first started kind of dipping my toe in this kind of world, I did reach out to a few people. And I think most people who are doing it are pretty busy. And don't have the bandwidth necessarily to do that. I certainly remember a few people, like colleagues at work, not so much anaesthetists, but kind of other specialties, who have made a handful who have made slightly derogatory and derisory comments about my attention not being on my clinical work.
Really?
Which is a really interesting thing. I've also had a lot of people be, you know, reaching out to me, being very curious, wanting to know, wanting some advice, and you know, so it's definitely in the minority, but it's been a mixed reception, which is interesting because I think if I was, for example, becoming a postgraduate dean of medical school or something more typical, I don't think people would be asking these questions. So there's some interesting dynamics in terms of perceptions of industry and how the kind of health tech world is viewed.
Is that hard to handle? Being so clinical, you know, 2.5 days a week, you're in the hospital a lot.
I mean, because I do quite a lot of out of hours and on-call commitments, it adds up pretty quickly. I've got some kind of red lines in terms of what I want to do and what I'm not prepared to do clinically. I don't want to do any less clinical work because I enjoy it. Two, I think that kind of that clinical relevance can be lost very quickly. And also I don't want to de-skill. I'm at a stage of my my career where I'm still learning stuff all the time, and it's a degree of craft, and I don't want to lose that attention to detail and that and those skills. And already I'm you know, you can't be good at everything, and there's I'm aware. I was chatting to someone who's a surgeon who's really, I mean, she's brilliant. She's the chair of the NPS Foundation, which I'm a non-executive director for. Really interesting lady. She's no longer actually operating because she felt her kind of technical hands-on skills were degrading by not being full time. So I do think it's a really interesting challenge for people who to maintain their skills and their knowledge and stuff.
Where do you think that comes from, that opinion of industry and the desire to sort of neg you for it? Like I imagine it's different things in different people, but that it does seem like a fundamental, like at the individual level, I think there's so many, because I have the DMs, there are so many people wanting to explore health tech for various reasons. Some are being pulled into it. Some are just trying to find a port in the storm and being pushed away. And it'd be interesting to talk about your perception of what's going on the ground floor there. But I'm interested as to what that perception is and where that comes from, as to the animosity towards industry and health tech, because is that the same as how people would view a part-time role in pharma perhaps, or is that how they're perceiving health tech? Or you tell me.
I think it's people who don't fully understand and appreciate what's involved and what's going on behind the scenes.
Is it the expectation that a doctor remains pure clinical and anything else is reductive of their, I don't know, status or whatever? Is it that?
I think a lot of people historically, it's been a vocation, and people have kind of felt that kind of deep resonance with what they're doing, and people will go above and beyond and be very happy with that. And I think for various reasons, and I'm not going to get into the goods or the bads or the stuff, but you know, there's been a lot of loss of that for some people, of that vocational aspect, and it's become a little bit more transactional. And I think there's a kind of wave of people who have, in inverted commas, suffered the contracting position for the residents, for example, who feel very differently about how to interact with their the employer and what they do and how they do it. That's not to say that I mean, I don't think I've ever met one of the trainees or residents coming through who are not incredibly hardworking, driven,
Yeah.
and patient.
No, I hear you. I hear you.
But I think there has been a slight change in that, and that's kind of feeding up the ranks. I think industry is viewed with a lot of skepticism, because I think people think that they're constantly either being sold stuff or being taken advantage of or being capitalized. And I think there's such a bad track record of kind of good procurement decisions and good, the right stuff being bought, or drugs being slightly missold, or evidence for something whilst it's in vogue, and then suddenly actually more data becomes available, and it was actually shown to cause harm. And there's so many kind of narratives involved that I think anything other than kind of pure clinical is kind of not pure. And I was speaking to someone a couple of weeks ago, really, really interesting guy who'd done a lot of stuff at a very high level in industry. He said some of his former colleagues just refused to talk to him, just completely blanked him.
Wow.
Which probably says more about them than him. But that's pretty sad, actually, if you if that's how people view it. And I do think it is a lack of predominantly a lack of insight into actually what industry, however, whether that's pharma, whether that's health tech, whether that's med tech, all the different allied specialties that are kind of surrounding healthcare, which I think most people don't know about.
I was at an event quite recently on a panel, and the panel was 4 people that have left medicine doing different things, and venture capital, startup land. One person was clinical but was pursuing a startup themselves as an entrepreneur, and someone put their hand up at this event and basically said, I'll give the person on the end a pass because they're still clinical, but basically you lot are making the world a worse place. And it was, I had that sort of heart sink moment, that stomach drops out of you moment of going whoa, okay, that is not what I'm used to. And I was very aware that I was in a bubble almost of the positivity health tech bubble, where we can sort of laugh and joke. And it almost, do you know what it almost felt like? And I don't know how substantiated this is. The vibe was like we weren't suffering enough. And in order to be virtuous about what we were doing, we just weren't suffering, whereas all clinicians are suffering, and therefore, and it was a very, I did a lot of soul searching after that and reflection on it of whoa, okay, I need to change my demeanor a lot if I'm speaking to this audience, and I need to have more empathy, and I need to connect with more people like yourself, to learn more about what's going on the ground floor here, because I'm starting to get a little bit disconnected. And that's the sort of work I did on myself. I can also appreciate, the phraseology and all the rest of it. So if you've had a chat afterwards of look, that's, it's quite an extreme view, but at the same time, I'm still thinking, okay, the kindness, compassion, empathy, we need to understand each other. And that's broadly my thesis anyway with this podcast, and everything else that I do is I need to increase the flow of information so that everyone understands each other a bit more, because things like that wouldn't actually happen, because a few things would have been different. But yeah, it is interesting to me that I think the ground floor, of healthcare is very different, not very different, but I think it's definitely moved on and is different to when I was there. But I'm interested in your take on that. I'm interested in what is it like on the ground floor for clinicians right now? And this is the Health Tech podcast, so definitely talking about it from a tech perspective is interesting, because we have, on one hand, the hope from things like ambient scribes that are finally reaching the ground floor, and individual clinicians very much resonating with the messaging that they're putting out of this is actually going to tangibly change the way that you practice, and is going to take something off your plate. So there's some hope there, but at the same time, I'm seeing strikes, and clearly I'm getting all the DMs of people wanting to explore health tech because they're looking for port in the storm. So I'm really interested in your view of, you're a consultant and anaesthetist, you oversee a lot of people in that hospital, a lot of juniors and training, all that sort of thing. So what is it like right now?
Honestly, and this isn't meant to be like a moan-a-thon, but it is quite it is quite hard. I think it's expectations and the pressures and the scrutiny is huge, and that's not necessarily a bad thing. I think standards. I was going to say,
could you just expand on that slightly for me? So expectations, pressures, scrutiny. of what and from whom?
Let's take someone who's referred with a potential cancer diagnosis.
Yes.
They will be they'll be kind of essentially fast tracked through on a pathway with very, very clear the standards at which point diagnoses should either be made or not made, and a treatment plan should be implemented, and there's loads of stuff, loads of kind of standards and guidelines around this. The surgeons will be under a huge amount of pressure to operate on those patients, and they will be juggling both their cancer lists and their non-cancer work, their benign work. So they'll be under a huge amount of pressure to populate their list, to fill their lists, to do the work. Plus, on the side, they're doing all their kind of admin in clinics and stuff like that. Then the patients will come and have their operation. Now, actually staffing those lists is incredibly difficult, and that's across the board. So there's not enough bums on seats. So that in our trust, we don't have enough consultant anaesthetists for the work we do. We don't have enough ODPs and theatre assistants and scrub staff. So we're always kind of robbing Peter to pay for Paul in terms of trying to backfill rotas and so forth. Then then there's the outcomes in terms of how patients do, length of stay, complications, and so forth, whether the curative rates, the resection rates are good enough or not good enough. So at every single step of the way, the team are under pressure and under scrutiny. And those so for example, if a list is underfilled in theatre, then the surgeon will be criticised for underfilling it. If the list finishes early, then theatre utilisation, a different team will be worried about theatre utilisation and not maximising the capacity of theatre. If the patient's cancelled on the day of surgery, then someone else is asking a question as to why that happens. These are all legitimate questions, because actually you don't want patients cancelled on the day of surgery. You don't want theatre lists being underutilised. If we can't provide staff, then that patient gets cancelled. And then that patient then gets bumped onto another list, and that bumps another patient further down the road. So you've got all these kind of contributing factors, which are these are all data points, and different people care about different things. And actually, it's there's just tons of scrutiny, and I think the scrutiny is good, but it is absolutely relentless, and everyone's seeing it through their lens. So, for example, we've got a task and finish group to do with their surgery cancellations. That's not all that they care about, but that's their purpose. So that is the only thing that they're looking at. They're not looking at the other stuff. They're not looking at the referral to treatment targets. They're not looking at the resection rates. They're not looking at the they're not looking at the national screening programs. It's really hard, and you've got people who are just being pushed really hard, and you've got a handful of people you've got a tiny minority of people who are giving a lot of people a bad name in terms of getting in the system and so forth. But actually what you've got a ton of people working incredibly hard in what are fundamentally trying circumstances. And, the reality of trying to log onto a computer taking 15, 20 minutes. The other day, it took me 3 computers before I could actually log on. And
it's crazy that this is still the case. It's honestly.
And then you've got the kind of AI scribe teams out there selling solutions which people want. It makes sense to them, but there's so many barriers just to doing simple stuff, just doing basic stuff. And at every stage, things are just made a little bit difficult, not out of malice, but just out of either legacy systems or systems which aren't fit for purpose, or all the kind of problems that people know. And one of the challenges I have when I'm working with DrDoctor is I'm selling dreams, I'm selling visions. I'm saying, look, this is how we reimagine outpatients. This is how we reimagine kind of patient pathways. Doing stuff end to end is really, I love it, because it's kind of, I find it inspiring, because you've got this huge problem, and we're kind of helping to kind of dream up and make solutions. But sometimes people just can't get their head around the fact that, I try and print a letter and I can't, it takes me 45 minutes to actually find the printer that's connected to give it to that patient. And it's a very, actually printing a letter is probably like the worst example, but I had someone who sits in clinic, and she was saying, I phone patients, I then have to write the blood form by hand, and then put it in an envelope, write the patient's address on the envelope and send it out. And that's the reality. That's what like hundreds of NHS consultants are doing in trusts all around the country. That's the kind of stuff that we're dealing with. So a lot of the amazing solutions which are out there are so far from the reality, from the kind of, lots of people talk about lived reality, but the lived reality of frontline clinicians is like in terms of IT and tech, it's pretty miserable. And what people want isn't actually, that much. They just want stuff that works.
It's so difficult, isn't it? Because I've remembered this ever since I've been a clinician, and those early days of trying to solve these real ground floor problems that don't need to stand upon much tech. That there's so much that falls between the cracks because the way that the health tech world seems to have emerged and evolved is we're on this venture funding model, this, borrowed from Silicon Valley vibe of have a deep tech idea, raise a load of money, and then because you've raised a load of money, you now need a load of scale in a cookie cutter fashion to keep costs low, margin high, exit value high. And we need to copy and paste this into absolutely everywhere in the UK, the US, and blah, blah, blah. And then we'll get an exit and we can return our VC 100x. And that seems to be the route to innovation. At least that's how the health tech world definitely seemed in when I got into it in the earlier days of that. That was the blueprint. That was the model. You left to be a founder because you had an idea. You went to go and raise money, and that was the thing. And that leapfrogs and jumps over it takes 3 computers to log in, and that's X amount of minutes. And when you add that up, it causes a big problem. All of that just gets absorbed into the sort of, that's what we squeeze our staff to just get done no matter what. And it seems like, for me, we've never seemed to, in my opinion, because it hasn't been solved, the business model has never emerged, in my opinion, to actually solve so many of these things that squeeze staff, because happier staff doesn't add dollars anywhere onto a P&L or pounds anywhere onto a P&L. And that has always, to me, seemed like a fundamental flaw in the way that we're doing things, because we're not doing a staff survey and then financially penalising a hospital, because what hospital needs more financial penalising? Or why don't we have a fund that financially incentivises amazing staff experience and actually put that together? And can the government find £1 billion to stick onto that? And actually, that can create some processes that start turning things around. I don't know what it is, but that business model's just never emerged for me. And it's always been a struggle, because whenever we talk about deep tech, it always seems that we're pushing, I've talked about this on here a few times, but that we're pushing the technology frontier, but the adoption frontier is rigid and it remains exactly where it was a long time ago, which is not anywhere near the tech frontier. We talk about quantum, we talk about LLMs, we can talk about all this stuff, and we can talk about hosing data into places that are pumping out SaaS products that are completely unique to this hospital. We can talk about all of that. Fine. But the adoption frontier isn't there yet. It can't be adopted. And it sits on this bedrock of exactly the problems that you've just talked about. And that's this kind of dichotomy that I end up living in my own head, where I'm, even in my career, it plays out. I'm on here talking about all these weird and wonderful deep tech solutions, when at the back of my mind I lived that reality, and I'm just sort of in the back of my mind hoping it's changing. It sounds like it's not.
It depends. I mean, you're talking then about kind of staff survey and things, and in the kind of sustainability world, people talk about the triple bottom line in terms of how to kind of calculate benefits. In terms of the kind of environment, it's to do with the environment. I can't remember what the third thing, but essentially the cost of something, and the environmental cost, and then the human cost.
Right.
And so you might have something that's dirt cheap, but actually if it's kind of produced in kind of sweat factories in a developing world country, then that's not okay.
Yeah.
When we're kind of think about kind of designing products and implementing products and kind of going to market with stuff with DrDoctor, it's really frustrating and slightly demoralizing to think that actually all these things, which can make a huge difference for staff experience, that's not going to make a CFO sign on the line. Things to do with patient experience and kind of quality of care. It's an incredibly woolly thing, and actually, the things of like consistency and people get it with the NHS app, which is really kind of a really exciting thing that's being done. One of the big drivers is this kind of consistent front doors, this consistent patient experience, and like people are getting that. Is that going to actually get people to sign on the dotted line for a contract? No, it's not. Like, the different trusts have certain access policies, for example, and that can be a lever. So every trust, every team has got its agenda and different things, and it's kind of like whack-a-mole. Different things pop up, and you've got to fix that. So at the moment, maternity is not unreasonably either, a very hot topic in certain trusts. So Gloucestershire being one of them is being subject to one of the Baroness Amos review.
Okay.
So there's a huge amount of scrutiny on, even more scrutiny on our maternity services.
And sorry, just give some context on that. What's the review? What is she looking at?
So she is looking at there's 10 trusts in total that have outliers in terms of certain maternity results. And
in a good way or a bad way?
In a bad way.
Right.
And so what she's doing is she's looking very closely to try and work out what's going on and to try and kind of promote some changes. Okay, let's go down that path. Our hospital, our maternity services are amazing. There's incredibly committed, dynamic people working there. At the same time as this going on, what didn't make the headlines was that the CQC reviewed maternity services, and Gloucestershire was also one of the 3 which was felt to be overperforming. So on one metric, we're overperforming. On another metric, we're underperforming. So we're under intense scrutiny, which people listen to, but they kind of ignore the good news. So it's incredibly challenging. When we talked earlier about the kind of the challenge and the scrutiny, it's absolutely relentless. And this is with the kind of the headcount freezes, with the challenges with the ICBs, NHS England, all the implementation, all the stuff that kind of really supports change. And I mean it's probably pressure cooker is too strong a word, but it's an incredibly pressurized environment, even without that scrutiny, with really high stakes stuff. And then you've got a huge amount of external scrutiny, additional scrutiny coming in, which makes it incredibly tough for people.
Yeah.
And this kind of there's a danger to kind of implement knee-jerk solutions. And earlier you talked about stuff being done to people.
Yeah.
So it's very easy for someone to say, right, let's do this. Here's a solution. Let's use it. Anyone who's done any kind of change management stuff knows that actually it's like that's not the way to do it.
Can I tell you a story on that you'll appreciate, being an anaesthetist? So when I was training, one of the consultants just took it upon himself in one of the theatres to run, I guess, a pilot for. Do you remember? We've got the stickers for the syringes, right? For the different drugs, different colours, blah blah. Have you ever dealt with the ones with the barcodes?
I haven't, no.
And a system where basically you would scan and it would do inventory, but it would also do like utilization, and it would in theory it would then link to EPR and like all that sort of stuff. And the theory, of course, was that this was going to be amazing, and of course it's going to work and it's going to be great. And it was just quite interesting to watch just how big the gulf was between the theory and the practice of all of the unknown unknowns as to why this wouldn't work. It was enormous. Like it was just enormous. Like just so many things that you can completely imagine, because as soon as you, like in theory, you stick for people that don't know, when you do anesthetic drugs, like you draw all the different drugs up and they've got different types of drugs and they've got different colors and they've got different names. And so you put these stickers on and like blah, blah, blah. It just helps us all, not deliver the wrong drug at the wrong time or draw the wrong one up, et cetera, et cetera. So, but adding this barcode meant that it would have all these extra features. But goodness me, as soon as you miss scanning one bar, the whole system is down. So that's just number one. And then there's the mislabeling, and then there's the forgetting to do blah, blah, blah. And then you give less than what's on the thing. Like it was just so enormous. But yeah, that was that was the one that I lived through anyway.
And it's and we've got a similar thing for the kit that we use. And so our anaesthetic assistants spend a significant proportion of their time scanning stuff that you've used so that it can be ordered. Now, I'm not saying like inventory control and stuff isn't important, but actually that's not why people go into these professions. Like they didn't want to work on a checkout. That's basically what they've done. They're now working in a checkout in Sainsbury's. So it's incredibly hard.
I actually found it quite satisfying. I'm just going to say it. I did actually find it quite satisfying. And I was probably more of the closer to 100% utilization of the tech than anyone else. But I did. maybe, yeah. Anyway.
There's a couple of things I feel really strongly about. And one is about the need for bums on seats. So the current way healthcare is delivered, you need enough people. Like I talked earlier about, doing enough operations and all these targets and challenges. We haven't got enough staff, and you need people to be in the job, working, delivering the care. You need residents to be learning how to do the job, understanding stuff, learning the system, so that they can then be the consultants delivering from, senior-led care of the future. And I'm going to kind of try not to kind of stick it to you, but I think if everyone does what you do, then suddenly there's no healthcare.
I agree.
I
agree. Well, that's a fact. It's impossible to deny.
You need people who are actually there doing the job, delivering the care, whatever that is. Either doing the operations, speaking to people in clinic, holding people's hands, wiping their bums, whatever it is. You need a certain amount of kind of people there, and so I always feel slightly. Well, first of all, I feel sad when I hear people are leaving, because I think there's a damning indictment of the system and the problems of the system when people have had enough, when they've invested so much time and effort and huge amount of kind of personal and sometimes financial resource to get to where they got, and they're just going to kind of turn their back on that.
Yeah.
Now there's the kind of the sunk cost fallacy, and I think it's much harder for someone like me who's been kicking around in hospitals for, I can't remember how long it is now, but a long time, as opposed to someone who's only done a couple of years. So that's there is that. But I think it is genuinely saddens me, because I think actually what it's saying is the system has let you down. The system isn't supportive enough. It's not open to kind of entrepreneurship or new ideas or innovation or whatever it is, or it's just too hard. There's no let up, and I think there's a huge amount of kind of well-being resource out there, which is brilliant, but I don't necessarily think it's first aid last, right? Safety first aid last. And I think people having burnouts and needing to go to kind of professional support units and so forth is grim, and what we should be doing is trying to make people's lives better. And some of that is just the nature of the job, and kind of I think a degree of resilience needs to be built just by exposure. So I can think of a handful of situations that have properly stayed with me, that have been incredibly hard. I wouldn't say they've made me stronger, but they've kind of, they kind of certain things. And I think anyone from a clinical background this will probably resonate.
We can all
with
point to them,
certain things where you just kind of, you kind of will never forget. Like I remember, for example, pushing a patient away from their family to go and have their organs donated.
Wow.
Like the kind of the howls of grief from the family, like, never forget. Stuff like that, which is, no amount of training, no amount of stuff will ever help you with. But this is stuff that you kind of absorb, and when you're absorbing that, as well as the kind of the daily crapness, the fact that let's use the computer login. Use the computer login as an example. And it's kind of some big cuts, and I think you're kind of geared up for that. But it's the smaller cuts which I think really kind of.
I would agree, and I've got a couple of things to say on this. The resilience and the strength that you gain from an experience like that, I think, is different to a lot of what does drive people out, myself included, is to in fact, a lot of people more so than me. I wouldn't say this was a driving factor to me leaving, because I was more pulled out than pushed out, if that makes any sense. I was more pulled out by what I wanted to do rather than being pushed out by what I didn't. I know that's not the case for many, but there's a lot of how people treat each other in medicine, and there's a lot of friendly fire, and there's a lot of, I don't think we need to be so unkind to each other, and the hostility that people will find trying to sell a scan to a radiologist or get a cardiology review or get all of these. There's a lot of hostility built into the way that we treat each other, and actually, I can point to a few, more than a few of these types of things where it really made me question, like, is this an environment that I want to be part of? Because it keeps coming up. The way that my training program directors treated me when I wanted to take a fellowship year to do the National Medical Directors Clinical Fellowship, and I had to resign it. Like, people, you hear these things about people having to resign reg numbers to take a fellowship within the NHS. Like, it was bizarre how there was all this friendly fire, and it didn't feel like we were kind and compassionate to each other, and that always frustrated me. I think also, from what you've said, the sadness of having people leave and the system letting people down and all the rest of it, a couple of things on that. I used to talk about leaving as if it was a flex. I used to talk about leaving as like, yeah, I left. Like, I did the thing. I left, blah, blah, blah. I've grown up a lot since saying that, and I point a lot more. I can point a lot more in my own mind to the luck that I had in leaving. Actually, the timing, the bizarre collection of things that happened that allowed me to leave. A single WhatsApp message put in a WhatsApp group of fellows advertising a job that I ended up getting. Had that have not been the case, I honestly could still be an anaesthetist. There's so much luck involved to me leaving at the time I did, as well as, you can create your own luck and put yourself in the right places and all the rest of it. I acknowledge that. I'm not trying to humble brag here, but like, there's that I used to call it a flex. I very much don't anymore. I don't think it's this amazing thing that I left. I think it is just the fact that I left, and I apply my skill. I can see the areas where that's good and it benefits healthcare overall, but I can also see, it left a gap, and if everyone does it, it's not a good thing. I can appreciate that. I would also say this is why I truly believe people like you are so important, because if I'd have seen you and your portfolio career of what you can do doing both, it would have inspired me to do the same. And I think that is a great answer. I don't think it has to be this all or nothing that piles loads of risk on the individual, and also the system ends up worse off because someone has left. I don't think that has to be the case. I think there are so many entrepreneurial medics. There are so many medics interested in technology. There are so many medics interested in computer science, engineering, and frankly, art and design, and all these other things that can contribute when you open the conversation of medicine and medicine and is so powerful, because we've seen the health tech and biotech worlds exist. I mean, biotech obviously historically, but the health tech world more recently evolving into this fully fledged industry where you can be a medic that is interested in tech but has skill in art and design, and you can be you can be in brand, you can be in marketing, you can be in all these things that we do, and that can add significant value. But you can also be a clinician with the other half of your time. And the medicine and thing is super interesting to me because it just wasn't available. Because if I'd have had, a potential training mechanism where it was part-time training in this and then part-time to do this, and that's the stuff that used to light me up. And I was just doing what I could to find those opportunities. It just so happened that for me, the easiest thing was to leave at that point. But I can completely see, not that I loved medicine, but loved it as a hobby. If I could do medicine a couple of days a week, and I like it, I can see that path. And I'm not saying that I would have been great at it, doing it that way. But I medicine and I think in this next iteration of education and training and how that relates to health tech, and frankly the evolution of the health tech industry as a whole, and gaining empathy for what clinicians go through, for what patients go through, and for what the tech world needs to deliver, I think increasing the communication in all of those fields by medic I think is very interesting to me, and I'm sure that plan has holes. But yeah, that's where I sit on all of that stuff.
Yeah, it's interesting. You talk about the kind of, I don't know what it's like to kind of leave. I'm probably, if I'm honest, I'm probably not brave enough to leave. I don't know whether I could. I don't think I would. I think the kind of patient stuff really matters to me. And some of that I think is to do with the kind of the sunk costs, both for me, but also kind of my parents and sacrifices they made. I think there's lots of kind of layers and context to it. But I think there is a danger that it can be viewed with kind of shame or kind of people can.
I have some shame now, like genuinely, like especially in those conversations where that person heckles and then reminds you of like,
But I don't think it should be. I think there's danger with what I'm saying, is saying like, we need bums on seats, we need people to do this stuff, and I know for a fact that the clinician founders I know who are making a go, who are having the big impact, they could not do that if they stayed in their clinical job.
Yeah,
there comes an inflection. There's
a tipping point. Yeah, absolutely correct.
And I think if you want to achieve scaled impact, I think there does come that point where you go, you know what, I can't just do this as a side hustle. This needs to become the reality. My kind of pathetic entrepreneurial side hustle, which is running conferences and stuff.
Come on.
No, I mean, but like running conferences and stuff. So like any anaesthetics, like anaesthetists out there, I run a conference for you.
And there's plenty of those. There's plenty of those. What a bizarre quirk of the world that is.
the lycra-clad anaesthetists of the UK. Yeah, that kind of stuff is truly just a kind of little distraction. It's a fun little pet project. But I think setting up for yourself, like marketing communications agencies, like something proper, like setting up some of the AI scribe founders, for example, like Don doing amazing stuff. Like you could not do that with alongside a clinical career, and you shouldn't, because you'll end up doing a bad thing of two things. So I don't think there should be shame. I think it's just a shame that so many people feel like they're being pushed out due to the infants environment, which is bad. One of the most positive things that has happened in the last few years in terms of postgraduate training, I think, is the fact that you can go less than full time without needing an excuse.
Wow.
So it used to be that you could only go less than full time if you had childcare or caring responsibilities. And a couple of years ago, NHS England, Health Education England, trialed this in, I think it was emergency medicine, where the burnout rate was just horrendous. And funnily enough, loads of people said, yeah, I want to go like less than full time. And they had fewer people quitting. And now anyone can go less than full time if they want to. Now, from a kind of staffing perspective and manning rotas, that creates challenges. But let's just kind of park that, because I think that actually if you have fewer people quitting and burning out, then you'll still have more kind of bodies on the rota. So I think it's important to kind of see the big picture. But that's amazing, because it enables people to have a bit of stability, a bit of develop a proper interest outside of work. The change fatigue that people undergo in healthcare is absolutely relentless. So I wrote a 5,000 word essay on this for a PG cert I did years ago. Talking about change fatigue and the fact that you're constantly changing hospitals, you're changing teams, you're changing subspecialities. Each hospital has got its own codes to get into the changing rooms, and they change every few months as well. Different logins, different passwords. Each trust you move from and to has got a different kind of crisis point. So we talked about the kind of whack-a-mole. There's different fires which are burning hotter in each different one. You're adapting to that. Each individual list you're doing, you're working with a different team. You're working with different consultants. It's absolutely relentless.
It's just cognitive load, left, right, and centre. Even just being the new person has cognitive
100%.
load attached.
And anyone who starts a new job, will say that the first couple of months is really hard.
Yeah.
Well, imagine doing that every 4 to 6 months constantly. It's really, really tiring. And if you're doing that, whilst doing exams, whilst with young kids, whilst commuting long hours, commuting, whilst working nights and all those stuff, it's it's not a surprise. It's
then bloody health tech companies messaging you, asking you for free consultancy. Honestly.
So yeah, separate kind of words. I think the kind of portfolio reality is important to kind of be transparent about as well, though, because I would love someone to take my hand and say, look, this is how you should do it, and kind of this is what I've done. As far as I'm aware, there's not a whole bunch of people like me, and it's a kind of slightly lonely place, I think, if I'm honest, in terms of I go to conferences and I meet people, and there's some really, really wonderful people with clinical backgrounds working in and around health tech, and it's amazing, actually. I really, really like the kind of the ecosystem, but I think most people are so busy and it's so relentless that actually people haven't necessarily got the time to carve out to kind of do that kind of formal mentorship type thing. And I think the other reality is I've got 4 calendars that I work off, possibly 5 actually. I've got 6 email addresses that I have to monitor in terms of juggling stuff, plus kind of WhatsApps and communities and LinkedIn's and other stuff.
I hear you on that stuff, yeah.
And like today, I thought was a day off, and just before this call started, I had a message telling me that I was supposed to be working later this afternoon, and had a childcare fail, and I've been scrambling to try and sort out childcare for my kids to be picked up from school. So that's kind of the reality of, I think, a portfolio career in my hands. It might be that my admin skills aren't good enough. It might be that the kind of the firewalls and the different email accounts in different organizations would allow some more transmissibility, but it's that's not the kind of rules that I'm playing in at the moment. And it's incredibly the context shifting is hard, but what it does give me personally is an amazing insight into for example, what does a frontline clinician want from a outpatients hybrid healthcare solution, for example, with the doctor stuff?
Yeah.
What does on the industry side? What are the questions that people want to ask?
Yes.
When I'm speaking to designers, I can say, actually, I know someone who's really motivated into this. Let me introduce you and have that conversation and see what the this whole kind of process of co-design to make stuff work. My board roles mean that I appreciate what it's like for an exec team to report in and to kind of have those constructive dialogues and to have that challenge and to work out, actually, okay, what does business development look like from a board level? If you've got a big research agenda, what does that look like in terms of kind of staying true to yourself, and how do you kind of keep yourself on that kind of mission led approach? It's brilliant, and it consumes a huge amount of me, and I would probably be, I don't know, not bored, but I'd be quite frustrated, I think, if I was doing less. But I tiptoe pretty close to being burnt out some of the time. Yeah. And that's not, I'm not saying that as a badge of honor at all. I'm saying,
how do you manage that? How do you manage that out of interest? Can you spot when you're getting close to the line, and do you have any techniques and processes to claw yourself back?
I've got a few things I do.
I asked this very selfishly, by the way, because I'm like, okay, interesting. I can learn something. Yeah.
So I do a lot of exercise, do a lot of sport, and so going to the gym and blitzing myself for an hour is a really good way of just kind of decompressing. At the moment, I'm jumping in a frozen pond in the garden every day in January, which is hellish, but wow, that's a fun thing to do, like just in terms of taking yourself into a different space.
I've heard for the mental resilience as well, doing something you really don't want to do every day just helps build that muscle.
I tell you, James, that the amount that I don't want to do it each day is I cannot describe. It is.
Joe's really funny. I actually saw a Joe Rogan clip the other day, and he obviously does it, and he was saying that a lot of people will congratulate him for doing it every day, and he has the same response every time, which is that every day I almost don't.
Yeah. It's just
I have no idea how close I am to not doing it every single day.
It's really hard. But I think there's also kind of like, I know when I'm being a kind of particularly grumpy dad or a particularly grumpy husband or particularly short. I know when I'm tired. I think there's certain things when I can't really be bothered to do stuff. So like if I can't really be bothered to like separate the recycling, that is a sign that like,
So
you know,
just
little signs that I get. Sometimes I will, I'll just kind of make a list, and I'll just be like, as I'm writing the list, I'm feeling overwhelmed, and then I'll just like, okay, right now I've got a lot on. I think that the nature of life is its peaks and troughs, and you know, the kind of the relative trough of kind of Christmas, and like, you know, we're in early January now having this conversation. Things at the moment are actually in a really nice kind of low level, bubbling along way. It'll pick up, and then it will kind of, as it comes to a kind of year end, like as it approaches April, for example, all the contracts will need to be signed and all the budgets will need to be spent and things will kick off and stuff. And then it will settle down a little bit, and then it'll fluctuate, and that's okay. But I don't know. There's I remember a couple of years ago doing a kind of time management course, and it was brilliant. And the one thing I kind of took away from it was I need to color code my calendar. And then I went to all the kind of IT people, with the different people I work with, and said, look, can we amalgamate all these into one calendar? And they all said no. I was like, okay. Well, I tried.
There was one actionable thing that tangibly changed my life. It can't be done. Awesome.
I love what I do, but it's hard and it takes a strain. And so I would wholeheartedly encourage people to do stuff that they find energizing, because there's different bits of what I do that I find energizing. So there's some stuff that I do in different kind of stuff, in different roles that I do, that I just do, right? Not everything can be exciting, not everything can be fun. You can't spend your whole life in a kind of icy pond, right? You know, that's like bad for you. You need the mundane. You need some stuff where you go, oh, right, this is you know, important, but maybe it doesn't float my boat. A really good example is clinical safety. Okay, I don't get that excited by it. It's really important. I work closely with a great CSO in DrDoctor, and he does like more than 90% of the load carrying on that, and that's brilliant because that kind of frees that off my plate. But that is something which is like, yeah, I'm glad it's not my everything, but it's a part of my portfolio that is important. It's important to keep up to date, and it's important to be involved in these processes and stuff like that. If I just did that, I'd go nuts. But occasionally dipping my toe into it is good. If I just did kind of high stakes pitches and presentations and public speaking and events and running conferences and all this other stuff, I would be absolutely exhausted. And that's also not sustainable. So there's different, you know, it's finding a bit of a mix, and actually the kind of this, maybe the kind of my training years prepped me for this, because no week is the same. In terms of not, you know, my job plan has got quite a lot of flexibility in it and variety in it. My clinical work, my diary changes constantly at DrDoctor with, you know, short notice calls with NHS clients and stuff, and different teams will kind of drop in, ask me stuff, and it's incredibly varied. And that's really good, but it is a kind of slightly relentless kind of pace of change and context shifting. Yeah.
Which is why you've got those canaries in the coal mine, and you have a plan to do something about it, which I think is so important. And just the self-awareness to know that stuff, to just stay not burnt out. And because you're right, putting a portfolio career together can look great, varieties of spice of life, etc. But you know, it's never just that percentage. There's always a few extra percent, and then there's the channel shift, and then there's all the rest of it that can creep up on you and end up hurting you. Before I let you go, clinical product lead at DrDoctor, what is clinical product and why do you like it?
Oh, I love that question.
I'm seeing loads, by the way, about product and particularly clinical product. I'm actually seeing quite a lot. And for me, it's great because it's almost like it's a real tangible one for me, seeing how the health tech industry has grown, that there are niches within niches now. I mean, to even say the word health tech, 13 years ago would have been like, what do you mean, digital health or like health IT or all that sort of stuff? And in that sort of 13 years that I've been doing this stuff broadly, God, it's come such a long way. And now we've got a whole Substack. Like Louise Ricks is on clinical products. Like, yeah, like there's a whole Substack on it now, and there's hundreds of people on that, and they're all doing clinical products. I'm like, wow, this is awesome. Yeah, talk to me about it.
So what is clinical product? My understanding of it is that it's about the kind of design, the implementation, the safety, and the advocacy of safe and robust, clinically focused products. And so, for example, they might be kind of admin adjuncts. They might be kind of pure clinical tools. But it's about bundling that together and making sure that the right structures are in place around those, so that when they are deployed and they make sense. They work for everyone, not just someone sitting in procurement, but actually the frontline user, and that's the staff and the patient and the team who are then, the admin team working with them and the back office staff and so forth. And it's tying all that together. Is it product management with a clinical lean? It probably is. But I think it's kind of tying all those things together. And I think the advocacy is really important as well, because it's making sure that none of those voices in the room get ignored. I remember doing a workshop and people talked about all these different stakeholders. It was a kind of change management 101, stakeholder mapping, all this stuff. And I was like, well, what about the patient, right? And they're like, oh yeah, this is the person that's actually going to be using this stuff.
Yeah.
So it's those kind of that kind of advocacy that I think is really important. And so that's what it means to me. Why do I like it? I like it because if you get it right and you build the right stuff, then it's not only easy, or not easy is the wrong word. It's not only implementable, but it can be scalable, and that has huge ramifications in terms of impact and doing good. This kind of supply demand problem that healthcare's got at the moment is massive. It's really damaging. It's damaging for patients. It's damaging for staff. It's damaging for the economy. There's so many things. But if you can get that right, if you can do these little tweaks, if you can improve things along the way, you can make a huge difference. I was giving a talk in December about kind of some of the stuff we've done with cancer pathways. And, we're not inventing new drugs. We're not kind of harnessing robots to do loads of amazing surgeries. We're not kind of, pressing Control V with a whole bunch of surgeons and kind of all that kind of stuff. What we're doing is we're taking the whole pathway and doing things incrementally at each point. And one of my immense frustrations and sadnesses is that the adoption and scaling of solutions, and just for the record, it's not just about DrDoctor. This is about all kind of health tech solutions out there. The trust which you've got the most bandwidth, be that financial or be that kind of headspace or infrastructurally robust enough or digitally mature enough or whatever, they're the ones that are already further on their journey, and they're the ones who are able to kind of get the highest return on investment. If you've got a underperforming trust who has got really bad architecture, bad infrastructure, they haven't got the headcount, they haven't got the skills, they haven't got the resources, they will tip. And people talk about health inequalities, and people think it's just about the kind of the headline health inequality things. But what about actually at a trust level?
Yes.
DrDoctor have got a huge footprint across country. Like the number of kind of patient logins we have each day is astonishing. The number of staff logins we have each minute blows me away. But there's a danger that it can concentrate again around various centres where this stuff is being rolled out and used at scale. Whereas the trusts who really need the help are the ones who aren't there, who haven't got this enormous kind of innovation infrastructure built around them, who haven't got, let's say university hospital status and the funding associated with that, as an example. That's something which I think is something I really struggle with, and that's that kind of inequity of implementation and rollout. Is
what happens as that gap keeps widening? Because it can't keep widening indefinitely, and you end up with these terrible places. And do the amazing places end up increasing the population and swallowing more regions up, and those bad ones disappear? Like, what's the actual end of that?
Yeah, it's interesting because I think the ICB changes might point a little bit towards that, don't they? So the fact that you've got these mergers, so maybe the kind of bigger, more robust ICBs will, what you're seeing is those absorbing the kind of slightly more precarious ones. I don't know. I think there's anyone who's been through a kind of a takeover, however, whatever that phrase looks like, will tell you that actually, it's not always an easy process. It needs to be handled very carefully. I've worked in some hospitals and some trusts which have been an amalgamation of services and things, and it's not easy. In some places it's been handled incredibly well, and in some places it hasn't. Gloucestershire is a brilliant trust. You've got Gloucester Hospital, you've got Cheltenham Hospital. I've got a handful of colleagues who refuse to cross the M5 and go from one side of the county to the other, despite the fact that it's been one trust now for, years. They're the exceptions rather than the rule, and you've just got to accept that. But I think these kind of amalgamations are, they take their toll, and it's more change, there's more upheaval. And I posted something on LinkedIn a little while ago about kind of doffing my hat to all the people in NHS England and in the ICBs who have had their jobs threatened, but who've carried on going to work, delivering, and try and do a really good job. And the number of people who kind of reached out to me kind of personally in the comments and stuff, who have said, actually, this is, the relentless change, the relentless kind of landscape shifting is really hard. And there is a place for kind of innovate or die. There is a place for kind of, constant evolution, improvement. But I do really feel for people who just need a bit of stability, and just need to kind of just focus on doing the job for a bit and just get used to kind of what the landscape looks like. Because what we've seen it's felt like for the last kind of year is, there's been decision fatigue. No, sorry, not decision fatigue, decision inertia, because no one's known who's going to have the budgets. No one's known whether they've got a job. No one wants to be held accountable for a bad decision, and that's going to make their job be scrutinized and so forth. And that's hard from a kind of, from a health tech perspective, from the industry side, in terms of trying to kind of sell stuff and try and get stuff out there and try and get stuff used. But also, we talked about kind of compassion and stuff for people in the public sector. Well, imagine what it's like for them, people who are scared to kind of make decisions, people who don't know if they're going to have a job and all that stuff. It's brutal. It's really brutal.
Yeah. And it's funny, Lawrie, I've really enjoyed this conversation, Lawrie. I think it's been amazing having you on. I'd love to get you back on to talk about more stuff. I feel you have such an amazing view of this space and an ability to very eloquently articulate so many of these problems. And I believe that you also probably have quite a lot of solutions in mind, not least the fact that more kindness, more compassion, teaching that in leadership and management as well. And I just wonder, first of all, do you have any aspirations of leadership within the health system to enact greater change? Or is your interest in technology with the likes of DrDoctor, and I have a word to say on them before we finish, but Tom Whitcher being one of the very first people I ever spoke to in health tech many years ago. But do you have any ambitions at that kind of level? And what is there value in teaching a different style of leadership? I believe you are, aren't you? Actually, isn't it one of your courses?
Yeah. So I'm running something. It's an experiment. It's like a kind of immersive 2-day kind of, I suppose, like kind of fast track change management leadership.
Right. Change management as well. So it's like the implementation of stuff. Retreat
sounds too strong, but the idea is this kind of it's like kind of 2 days really kind of intensive, just kind of thinking about this stuff and teaching stuff like how to, what are the different levers that need to be pulled for different people in order to make stuff happen.
Valuable. For clinicians, is this?
Yeah, for clinicians.
Yeah,
And
so this is about,
it's kind of showing people that you spend kind of, I think, 7 years postgraduate training to become a consultant anaesthetist. You get spat out at the top, and then someone says write a business case, and you've got the same amount of experience writing business cases as an F1 in their first week a lot of the time. There's a whole language that people don't know how to speak. There's a whole different approach. I don't think you can be all things to all people. I think sometimes you need people who are kind of clinically focused, and you need some people who can, the kind of management tier who can really kind of navigate this kind of world. So we're trying to kind of work together with some brilliant people. We've got an amazing faculty who are going to try and help kind of nurture this group of people through. So I think there is a space for this kind of teaching different ways of doing things. I think the fact it's so hard to navigate should also be a little kind of warning sign. If I think about some of the things that I've kind of inverted commas achieved as a consultant and just how hard it's been, and these are things which have been like totally legitimate patient safety concerns, and the amount of time and how slow the kind of wheels of change move. And then if you kind of shine the light on kind of health tech startups, and you think about the kind of capital that they're burning through whilst all this kind of these slow processes happen, and the impact on that, people have this kind of runway where they've got maybe 6 months of money left, and they need contracts signed, and they need to go live, and actually if the chair's off for a board that it doesn't happen, and then it's postponed, and then it doesn't make it on the agenda the following month, and then actually the agenda's backed up, so something else is a problem. This is a reality.
Yeah, it's practical reality. Yeah, 100%.
But it's incredibly difficult to implement change, and that's from within. From outside, it's incredibly difficult. And I think all those layers of skepticism and cynicism about industry, and it's kind of work. I suppose the ideal state is when you're working with, rather than kind of working against, or seeing yourselves as kind of different sides of the solution. So when you're a development partner, that is amazing. When you're properly spending time with teams embedded, where those kind of connections are real. So I remember going on site with one of the, she's left now, she's gone to Canada. Sierra, shout out to you if you're listening. But we went on site to one of the trusts you've been working with, and the one of the transformation team on the trust side ran up to her and just gave her a huge hug when she saw her. And I was just like, that's amazing. This is someone who's just interacted for months on Teams, and we clearly have bonded, and just such a great relationship.
That's so nice.
And that's kind of testament where people are really working kind of hand in hand, kind of walking in the same direction. And I think that's the thing is I don't think there's much space in this ecosystem for people who don't have a genuinely good agenda. You talked about the kind of grubbiness of the kind of VCs funding cycles and stuff like that. I really don't. I haven't seen that. I think there's a lot of people who are incredibly mission-led, who are trying very hard to do good. And I think once you kind of get past that cynicism and that skepticism and that reticence to engage and actually do stuff together, it can be absolutely game-changing. But it kind of takes time to build that trust and that relationship. And usually then it's time for contract renewal, and then it goes back to square one.
Well, that's a lovely message to finish on. And just a quick word about DrDoctor. I mean, Tom, absolute legend of the health tech space. I mean, he literally was one of the, that job that I mentioned, I just saw in the WhatsApp group and ended up applying to and ended up getting. That was to be a navigator at the Digital Health London Accelerator. And as part of our induction, Tom gave a talk to us 4 navigators of like, this is what a health tech startup is. Like, I am one. This is what that means. And yeah, I think they were, bootstrapped at that point as well. And yeah, he's been in the space longer than I have even. So yeah, always a pleasure whenever I see Tom and speak to him. So, and DrDoctor, obviously an amazing company doing incredible things, literally the OG of the space. So yeah, fair play to you. It was always one of my backup plans in my mind, actually, to, if ever anything went wrong, to just beg Tom Witcher for a job. That was always in the back of my mind of like, this is a guy I could work for, definitely. And you'll know that having working for him.
I mean, you talked about good fortune in terms of kind of your transition. I've been incredibly fortunate to kind of to work with our team. They are, without exception, a really dedicated, dynamic, motivated, and like, so, it's that mission which I think aligns with my own personal values, which counts for so much.
Well, I was actually going to say making an actual difference as well, and actually going in at the point of, not quantum computing, let's solve a problem. Like that's what I've always respected about the DrDoctor way of doing things.
Yeah. So, I feel very fortunate. If they're listening, thanks guys.
I'm sure a couple of them are. Yeah, Lawrie, absolute pleasure. Thanks for coming on, man. If people want to get in touch with you for any reason, they've been inspired by what you've said and want to ask you a question, what's the best way for them to reach you?
Probably like most people, LinkedIn. I think there's only one Lawrie Kidd on there. So that's probably the best way. I try and kind of respond to DMs. Like everyone, quite busy, so I'm sorry if I'm slow. And I always like it when people connect, but I always like it when people actually explain where the connection request came from. It makes it so much more personal. Even if it's just, LinkedIn suggested I made friends with you, that's fine. But
they can say they listen to this, right? They can say they listen
100%. Yeah, they can. They can tag you. But no, it's been an absolute pleasure. It's a real honor. Like, I've listened to a ton of these, and
thanks, man.
It's really great, and I mean, for you and your team, Karen, what you're doing, because it's great.
Thanks, buddy. We'll speak to you soon.
All right, Brill. Thank you.